Hi, it's Dr. Centeno, and thanks for joining me. Starting just a few minutes late here today. Still working on some issues with the new place and trying to get the office down pat. So angle of the camera is a little weird today. Sorry for that. So what we're going to focus on today is an interesting topic. You know, a lot of times what I'll do is I'll see something during the week and seeing the craniocervical instability patients that I treat, and I will ask myself a question. And in trying to answer that question, it kind of turns into one of these videos. So this was an interesting situation. I had a relatively young woman. She was 35 at the time. She had a CT scan that seemed to show a lot of bone spurs in the craniocervical junction and upper neck. Now, to me, based on my experience, I felt that probably indicated that she had craniocervical instability at a young age, and she was showing those at age 35. But I wasn't able to cite the research behind my assertion that those two things were connected. And so the question was, how common are upper cervical bone spurs? And especially, how common are they in young patients? So we're going to get into that today. We'll talk a little bit about what is a bone spur. We'll talk about the craniocervical junction, the C2-3 level, how common these things are or aren't, and then kind of draw some conclusions from what's been published. And then obviously I'll get into answering questions, whether it's about this topic or any topic at all. So let me go ahead and share my screen here. There we go. Looks like that worked. And we'll get started. Again, short lecture today, just trying to go over this concept of upper cervical bone spurs, and are they sort of a sign that you have craniocervical instability? So you may have been told that you have bone spurs in your upper neck. It's pretty common in the craniocervical instability patients I see. And then this week, I saw this patient, and she had a good number of upper cervical bone spurs. Now, this was a 2016, I believe, MRI, but already at age 35, she had this bone spur here coming off the anterior atlas, the superior atlas, this one down here coming off the inferior atlas. She had this bone spur over here coming off of the C2 spinous process. So quite a bit going on for a 35-year-old. I was like, wow, that's interesting. I don't normally see that in patients so young. If we go over here and look at the axial, she had more bone spurs along where the transverse ligament goes. There, and she was even starting to get some bone spurs around the dens bursa area there. So quite a bit going on for a young person. So I asked myself the question, what's the research on this? Is this something that I should be using as an independent predictor of craniocervical instability at a young age? Or is this just more common in people walking around who have no issues? So what is a bone spur? A bone spur, also called an osteophyte, is a response to instability. The body is trying to stabilize the area, so it's adding bone there. Now, most people think of bone spurs as evil. In fact, they tend to cause more good than harm, meaning that most of the time they tend to make the unstable joint more stable. Obviously, with craniocervical instability, therefore, we would see bone spurs pop up in most patients at some point. Now, we do know that degenerative arthritis and bone spurs go with this, like these down here, tend to commonly occur in the lower neck and in the lowest part of the low back. And so those are the most common areas these things happen. We know that lots of people get these. They're not necessarily related to pain. And so by the time the average person is in their late 40s, 50s, and 60s, a good chunk of those people who with no pain are going to have bone spurs in their neck or their back. So they're pretty common, quote, normal findings associated with aging. Now, there are some of these people that have pain, but a lot of them don't. And in researching this, I did find that as you get older, that this stuff is common in the upper cervical spine. But that's an older patient, 60 and above, and that kind of makes sense. But so that means that in older patients who have, we really can't use this as a way to say someone has CCI, because this is pretty commonly found in normal, healthy people walking around out there. I also found this. Now, at least this study looked at C2-3, which I consider part of the craniocervical junction. So we could at least answer the question of how common was this at C2-3. Now, this is the graph they used in the study, 1,500 patients. It's kind of a mess, so I switched it up here just to give you a better sense of it. So the height of this bar now is the amount of bone spurs seen, and these colors are the severities. So the red would be the most severe, the yellow would be moderate, and then the blue is mild. So you can see here that of all the cervical levels, the amount of bone spurs goes way down by the time you get to C2-3. And interestingly, all these other bone spurs in here at these lower neck levels are worse with age. So they tend to increase with age. That makes sense, right? Because we know this is sort of an aging phenomenon, but not C2-3. C2-3 didn't get worse with age. So that's a good thing to know. It fits with what we know about the C2-3 level and its stability. It's more stable than other levels based on a study a long time ago by Lynn. And now we're seeing independent confirmation of that, right? We're seeing that if you've got bone spurs at C2-3, that's uncommon and it's not associated with age. So it's probably an specific injury to C2-3. And then regrettably, this is not the best chart that these guys put in, but this is a couple hundred CBCT scans. So this is a study from a dental journal where they were taking CBCT scans for the jaw, and they happened to just look at the upper cervical spine to try to see what the prevalence of normal bone spurs were. Now, if you look at any degenerative changes, and in my patient's age group, 30 to 39, she's 35, about 19% or 1 in 5 people had some sort of degenerative change in the upper cervical spine. If we get into osteophytes, which are bone spurs, you can see here that the average age was 45, so older than my 35-year-old patient. So here I think we can conclude that in a young patient, it's not real common to see those bone spurs, but they're out there. So what sort of information can we take from going down this rabbit hole? And that is that in young people, we do see CCJ bone spurs in asymptomatic people, but they're not super common, probably less than 1 in 5. So a 35-year-old might be 1 in 6 or 1 in 7, but they're out there. So we can't use those bone spurs as an independent predictor that they have craniocervical instability. We might be able to use it as a way to say, well, they had this on their imaging that showed instability, and all of the other parts and pieces match up. So this matches up with the bigger puzzle. So the puzzle piece fits into place, but we can't take that puzzle piece out of the puzzle and claim that it shows the whole picture, because it doesn't. Okay, so let me get out of this here and I'll start answering some questions. Okay, let's see what we got. Let's see, I have small bone spurs between C1 and C2 is going to affect spinal cord or canal if left untreated. Not usually, no. Thanks, Stacy. Off topic of Spurs, is there a solve for severe C1 capsular synovitis? Synovitis basically means that the inside of the joint capsule has swelling in it, and that inside of the joint capsule can cause issues, problems, pain. So obviously the way to solve that is to try to get rid of, in this case, instability or whatever else is causing that swelling. Let me go ahead and I'm going to try to take that blurring off my background there because it looks kind of weird. Sorry about that. Okay, that's better. Regenetics advanced by DB. Definitely have these bone spurs, so thankful to know what they mean. What's the first test I should get to further confirm? Yeah, so again, if you're younger, then I think they could be more important. If you're older, then probably not all that important. But certainly, a test to look for craniocervical instability would be a good next step. The most common way to find that would be a digital motion x-ray, meaning that would have the highest likelihood of getting to a CCI diagnosis. And then down from that would be an upright MRI with flexion extension. Ulysses, can using prolotherapy, PRP stem cells get rid of bone spurs in the upper cervical or lower cervical area? Probably not get rid of them, but more likely reduce their ability to progress. Liam, how many weeks after PICL can I start trying the clock exercises? Yeah, Liam, so a lot of this depends on how you're doing and how you're feeling. So if most of the symptoms have gone away or and you feel like you can do more out in the world, that's a good time to start clock exercises. Now, the biggest information that we'll want from that is how far down the road can you get? Can you only do level 1? Do you only get past, you can get past level 1 and 2, but can't get past level 3. That's all important information. But if you can rapidly progress through all of those clock exercises, that's great. That'll strengthen the upper cervical spine. It also lets us know that we're making a lot of progress. Regenetics submitted advanced by Sherry Winston. What type of MRI is needed to rule out these bone spurs? MRIs can see them, but they tend to be less sensitive for this kind of issue. So a CT scan can do that, or many times you can see them on digital motion X-ray or DMX as well. It's been advanced by Craig Raleigh. Was told the bone spurs in my neck were just normal aging. I'm only 33. What tests are you to rule these in or out for all the symptoms I have? Brain fog, dizziness, neck pain while chewing, etc. Craig, in general, the digital motion X-ray would be the best one to do, in that it's the most likely to show if there's instability or not. You could also do an upright flexion extension MRI as well. Liam, it's worthwhile to do another DMX after 2 PICLs, even when the patient had a lot of symptom improvement. That's really up to you, Liam. It's not required if you continue to make symptom improvement, meaning that I don't want to expose patients to X-rays just to expose them to X-rays. But if the patient wants us to do that, we'll normally wait a good 4 months after the second one, sometimes even up to 6 months, before we'll pull the trigger on that. So that's really kind of up to the patient, risk benefit of getting more X-rays versus I really want to see if this is improved. Ulysses, does clicking, grinding, or piping mean bone spur, or popping mean bone spurs? Not really, no, meaning that that can mean degenerative instability in the spine, but doesn't necessarily mean bone spurs. Any other questions for me at all out there, guys? Talking today about bone spurs and the hypercervical spine. Trying to see if you've got any questions for me. I'm happy to answer them if you do. Anything else? So just sort of to wrap that up in the discussion on bone spurs, we were talking about the fact that the research seems to show that upper cervical bone spurs are found in maybe 1 in 5 to 1 in 7 young people. What I mean by young people is someone in their 30s. Far fewer of people who are much younger than that. So if we've got a young person with bone spurs like that, let's say in their 20s, it's more likely than not coming from something like instability. By the time you get in your 30s, there's about a 1 in 7 chance or so that it's coming from, it's just normal and not coming from instability. And then by the time you get into old age of 60s, it's probably not related at all to your instability. Karen, hi, Dr. Centeno, can you explain what the mind-dural bridge is? Do you inject it when you inject the neck? Yeah, the mind-dural bridge is a muscle connection, usually through the rectus capitis posterior minor, into the dura, or the covering of the brain. And it's theorized as having a function in, when you bring your head back, pulling the dura out of the way, to allow cerebrospinal fluid to continue to flow with your head in that position. It's a possible cause of headache. So if that area is particularly tender and we're seeing the dura buckle when the patient extends their head on an upright MRI, then we'll inject the mind-dural bridge. Stacy, can you treat bone spur in my SI joint? Well, really, again, Stacy, the bone spur is the downstream consequence of the instability. So the goal would be to treat the ligaments in your SI joint, reduce the instability, and reduce the joint's need to continue to throw bone spurs. Because remember, the focus or the purpose of a bone spur is to stabilize the joint. So we got to get the joint more stable so that it won't keep throwing bone spurs there. Stacy, can TMJ clenching grinding cause upper cervical bone spurs? I have a C1 ponticulus. Just wondering what may be the cause. So really what you're describing is a little different. You're describing usually an arch or a hole where the vertebral artery goes through that arch or the hole. And those are not really bone spurs. The person is born with them. So that's just sort of a congenital thing. By itself, that congenital little arch or hole that the vertebral artery goes through doesn't mean a lot. Now, in combination with instability, it may have more meaning. It's been advanced by Harry Winston. Will stabilizing the neck cause the bone spurs to get smaller over time? You know, Harry, I don't know that we know that one yet when it comes to technologies like we would talk about here, prolotherapy, PRP, bone marrow construct, et cetera. So we don't really know that one yet. Any other questions that I can answer that anyone has out there? Happy to answer any questions about this topic or any topic at all. Stacy, I have progressive x-rays from 2014 to last year showing the ponticulus growing though. Yeah, happy to look at those, Stacy. It's certainly possible that some of the attachments to that area of C1, like the atlanto-occipital ligament, may be yanking on it. And so it's not so much the ponticulus growing as it is a little traction spur forming from the tension on that area of bone. So definitely happy to take a look at it, but that's probably what that is. There are also muscles that attach to that point. Those include the rectus muscles on the side here, superior oblique, etc. Ulysses, can bone spurs happen in the skull? Yeah, the most common area we see bone spurs in the skull, Ulysses, is back here at the nuchal ligament origin, we see that a lot of people that do this all day get a big bone spur back there from the nuchal ligament pulling a traction spur there. So that's a super common one to see these days. Stacy had 11/4 hours worth of MRI at Pinnacle, not for our protocol because Dr. Rosa couldn't be there. Would the images be evaluated before becoming PICL? Oh, sure, Stacy. Yeah, I always tell patients I'll take as much information as I can get. So if you've got a really detailed Rosa MRI, I will be happy to look at it and see if it in any way changes the treatment plan. Other questions I can answer, guys? Anything else for me? Okay, so we'll start wrapping it up for today. This will be a shorter one, probably because we're starting to get into summer season here. And I'm sure you guys are starting to think about going on vacation and doing all that good stuff. So again, we talked about upper cervical bone spurs. What do they mean? Is it a big deal? Should you be concerned? If you're older, probably shouldn't be concerned. If you're younger, it may be that your CCI has caused those. And then Chris, can the presence of anterior osteophytes reduce likelihood of ALL will respond or tighten after PRP treatment, assuming that the ALL is loose? Probably not a big deal as far as reducing the likelihood that the anterior longitudinal ligament will tighten down. So not a big deal. Okay, guys, have a wonderful weekend. I will be here on Monday. I think I'm going to talk. Let's see, what was I thinking about talking about on Monday? Oh, I think we're going to talk on Monday about intracranial hypertension and some MRI measurements to look at intracranial hypertension. So can't guarantee it, but I think probably that's what I'll be talking about. So look forward to seeing you guys on Monday, same bat time, same bat channel, and have a great weekend. I'll see you Monday. Thank you.